All right, hi everyone. I am here with Samara DiMattia, and we are going to do a little talk for you guys on foot care and maybe some other injuries that I have some questions for. So Samara, do you want to introduce yourself to everyone?
Sure. My name's Samara DiMattia. I'm a dance physical therapist practicing in Stamford, Connecticut, which is just 50 minutes outside of New York City. I grew up in New York, danced my whole life, and became a physical therapist 20 years ago. I started my own practice 13 years ago now, and my practice is primarily dancers, figure skaters, and gymnasts. And I go into local dance studios and companies and do injury prevention seminars and point assessment and readiness and all that fun stuff.
Awesome. So I wanted to do this today because, so for me, I am a Pilates instructor. I work with both pre-professional and professional dancers. And of course, I am not a medical professional. I'm not a PT. I have special training in being able to work with people post-rehabilitation, but I always refer out for any diagnosis, any injury. In my area, we have really great, wonderful PTs, but not a ton that work specifically with dancers. And although I think that the diagnoses are fabulous, it's always so much easier when you go to somebody who can really quickly understand what the dancers are talking about and explaining. And the way I always explain it is I can work with a baseball player, for example, and I understand the mechanics of the shoulder, but I don't know the pitches. I don't know what, so they always have to be like, when I'm doing my pitch, I do this. And it just takes longer to get there versus if you were working with someone who was a baseball player, you would just say, when I do this pitch, and they're like, oh yeah, I know what's going on. So I really, really recommend that if you can find a medical professional that understands the dancer's unique body, it's so, so great. So Samara, you've been doing since the shutdown telehealth appointments. Are you seeing any new client or new patients?
I am, yes. So we had to kind of wait and suss it out in terms of what our governing bodies would allow. But in the state of Connecticut, I can treat both new patients and older patients via telehealth. And the kind of whole idea behind telehealth, for those of you that don't know, is like a one-on-one video consultation. And I can do a very thorough evaluation. Most PTs, we evaluate with our eyes anyway. There is some hands-on stuff, but I've gotten very savvy at having the dancer kind of do that portion of the evaluation. And then I can guide them on how to better help treat their injury themselves, whether it's with their own kind of like self-joint mobilization or even fascia release sometimes. And then I, of course, teach them exercises to do if they're dealing with an injury.
How much of your practice is manual versus exercise? I'm only bringing that up because, of course, that's the thing you can't do virtually.
Correct. So I am a manual therapist. That's what my training and my background is in. I come from a very long line of dance medicine physical therapists that are manual therapists. So I have had to tweak things a bit, but I would say a dancer that comes in to see me physically in the office, about 50% of their time spent here is my hands on them, and then the other 50% is doing exercises. So it's been a little bit different, and the treatment session is obviously longer in a telehealth because they're not getting that hands-on work. However, it's forced both of us, myself and the patient, to kind of really scrutinize and look at things. And in all honesty, I feel like it's been super beneficial in a way that doing an on-site appointment doesn't give you, which I'm very surprised to find. So I've really enjoyed it quite thoroughly, and it's been like professionally really helpful for me, if I'm being honest.
Do you have any suggestions? Because I foresee that in the new future, things are going to change. I know the Harkness Center for Dance Injuries started doing telehealth, and there's been a lot of places. I kind of am imagining that. So, for example, I have a client, they've been seeing a PT locally, but they don't have access to a dance PT. could you imagine that you could do evaluation with someone, give your expertise, and then they could take that to work with their local PT?
Yeah, so I do this all the time. I mean, I have dancers that move away or go to college, or so I'm constantly trolling, the internet and trying to find local PTs. And very often, which is astounding to me, because again, I come from New York City where you cannot throw a rock without hitting a dance PT. So when I hear that there's no dance PTs around, it's always so staggering to me. But this is a unique opportunity. Yes, you're right on the money there, Leah. Like, I feel like more of us will have access to these dancers and they can get better care quicker through the telehealth system. Absolutely, positively.
Nice. So let's talk a little bit. I was reading your bio, and in it, it said that you started your career at Westside Dance Physical Therapy. I would love to hear about that.
So I was actually Marika Molnar, who's one of the pioneers in the field of dance medicine, just had a wonderful, I don't know if people saw this interview through the New York City Ballet, is doing this like virtual season. Megan Fairchild interviewed her. Anyway, she's my mentor. From a very young age, she came to my high school. I went to Performing Arts High School and did an injury prevention seminar. I was 15 and I was like, that's what I want to do. So I kind of reached out to her then and I kept in touch with her I ended up dancing professionally, and then circling back to PT school, I was her first official PT aide that was just hers back in the day. So I learned, I would say, 85% of what I know is because of my relationship with her. For those of you that don't know, Westside Dance is the primary dance physical therapist for New York City Ballet, ABT, SAB. So we were in-house for that stuff. It was a wonderful experience for anybody that wants to go into the field. There's so many different avenues now. When I was coming of age in the dance medicine world, we really had very limited access, and there weren't a lot of people. She was really the first.
She was, yeah. I mean, there's some so for you younger dancers, she's also been on Tyler Peck's Turnout with Tyler. And if you want, there's some really neat old videos of her working with Makarova back in the day. And so yeah, cool. So she's definitely one of the dance med heroes. And that's so neat that you got to learn from her. Wow.
Oh, yeah. Mm-hmm.
Okay, let's dive in. So just so you all know, when I reached out to Samara to do this, I kind of asked, oh, is there anything that you specifically want to talk about that you're passionate? And I loved her answer. She said, I'm passionate about anything, or everything, excuse me. And I think that we could spend probably a whole day talking about things. So I like to narrow in the content. So what we're going to talk a little bit about today is foot care. It's definitely an important thing for dancers. Your feet are your livelihood, and if something goes wrong there, it can definitely be detrimental. Do you, Samara, have any, I guess, what is the most common foot-related? And I say foot-related because, as we all know, the hip can affect the foot and whatnot. What injuries do you typically see with dancers?
So most of our injuries, I would have to say, 50% of what I see is foot and ankle. So it's definitely the most primarily impacted joint, I feel like, for the dancer. Generally, we see overuse type injuries like tendinopathies, but occasionally stress injuries of the long bones, of the metatarsals, stress fractures, ankle sprains are a big one, and also impingements in the ankle, both posterior and anterior. And FHL kind of tendinopathy. Those are the big ones.
Can you explain to everyone, because I think people get confused of what is an itis, what is an opathy. So can you tell everyone what is a tendinopathy versus a tendinitis?
Sure. So the latest research with tendons shows that very often there's really no such thing as a true itis anymore. We have a dysfunction in the tendon, and the tendon can often have like micro tears and kind of fray a little bit, and or the sheath kind of surrounding the tendon can get inflamed and junky and stop producing synovial fluid. So that's like more of a tenosynovitis. The dancer will have like clicking and catching and funkiness happening in there. So as a PT, I have to kind of assess where they are in that continuum. Like, is this a newer kind of tendon injury? Is it something they've been dealing with for a prolonged period of time? And ultimately, it always, 100% of the time, is a biomechanical issue that does just need to be fixed. So the old kind of thinking was you would rest the tendinopathy, but we don't do this anymore. We strengthen in and around it to build up the part of the tissue that is still viable and healthy.
Great. So I would assume that if we're going to talk about tendons, can we talk a little bit about the Achilles tendon? I'm really interested to hear your thoughts on the FHL tendon, if that becomes problematic.
Right. So it's very rare, based on my years of experience, that dancers have Achilles tendinopathy. It's most of the time FHL, but if they go to a doctor, again, that doesn't know dancers, they'll get diagnosed as Achilles tendinopathy. But I will talk about the Achilles. So the Achilles, very often, if you have kind of like a dysfunction there, most commonly it's at the musculotendinous junction where like the tendon becomes muscle. And the reason why that plagues the dancer for a really long time is there's a watershed there, meaning there's not a ton of blood supply that can pass through that to help with the healing process. Occasionally, we'll also get Achilles tendon issues at the insertion on the calcaneus. And I see a lot of younger dancers that are developing that can also have a growth plate injury at that area. So that's often, that's called Sever's disease or Sever's disease, and that's right kind of where the Achilles inserts onto the calcaneus. So very often they'll be given a diagnosis of Achilles tendonitis, but it's really more of a growth plate issue at the calcaneal apophyseal plate back there. Having said that, FHL tendonitis very often presents itself more on the outside of the Achilles, so the lateral portion of it, and the dancer will say, my Achilles hurts, but they'll always like scoop their finger around and kind of go underneath the Achilles. That's how you know. Some of the time it can also present medially because the FHL is a super long tendon that has this really circuitous deep root. So it depends on where it's getting impinged. But quite often it's more of an FHL issue than an Achilles issue.
Yeah, and then can you just explain to everyone what the FHL does so they can kind of start to put the pieces together for themselves of why they may have that?
Yeah, absolutely, positively. The FHL, flexor hallucis longus, is a toe flexor or plantar flexor and also an ankle plantar flexor. So I always say this to my dancers, do you ever do that? Like 5,000 times a day. In addition to that, it's very good at gripping the floor. So if you are a gripper, when you have a standing leg instability issue and you tend to hold on to the floor for dear life, or you're a toe cruncher, so when you point your foot, you do that last little bit of crunch to try to make it look better, or you do a tendu and you push into the floor. This is your FHL at work and your FHL being abused. Your FHL is really not meant to do any of that. He can certainly help us press up to releve, and he's really an integral part of going from that demi-releve to full point when we're in our point shoes. But he needs support from the posterior calf muscles for sure. He's not a very big muscle. He's pretty tiny, and also his, they call it a low-lying muscle because the belly actually is very, very close to the joint itself, which is unusual. So that's why we get the impingement issues there as well if it's a dysfunctional FHL. In addition to that, its long tendon goes, through this tunnel on the inside of our foot and then inserts on the tip of the big toe and travels between these two bones called your sesamoids. So there could be a pathology in the sesamoid bone that can kind of have an interplay with the FHL, I find.
Good. I'm glad you brought that up. I had a sesamoid question that I just thought of, but I'm going to circle back around to that. So
Yes.
One of the questions that I got that I think is good to talking about the FHL. So a teacher wrote in and she said that a lot of what they do in pointe classes is they'll have dancers go from practice the action of going from 3/4 point to full point. And that's a repetitive motion that they do over and over again. Do you feel like that exercise could be contributing to overactivating the FHL, or is that okay to do?
So I unfortunately have to say that that is largely dependent on the dancer and the point shoe and where they are at their stage of training. If you have a dancer that is doing that action, but is kind of sinking into the shoe as they're doing it, and or it's a really hard shoe and they have to really push to power through, that could definitely create a tendinopathy in the FHL. And really what we want to emphasize is that the dancer is using kind of more of their posterior calf to do that. Having said that though, the FHL does need to be strengthened. So I think the short answer is if I see a dancer doing it and she's doing it healthy and she's not sinking into that back part of her ankle as she's doing it and or crunching her toes as she's doing it, as she's keeping her metatarsals long, then ultimately that they do need to develop the strength to do that. That is how you press up onto point. So
Great. So we're going to think, so it's the dysfunction of movement, and that's where all of these tendinopathies come from, is it's not the action, it's the dysfunction of the action.
So if you're able to do that in a healthy way, I would say it's an adequate strengthening exercise. And also if you don't have an active kind of inflammatory or something going on in that tendon, then you probably don't want to do that because it could stress the tendon.
Great. Can we talk a little bit more about Sever's disease and what you do? Because that's, to me, is a very common thing, especially with young dancers.
Yeah, so so let's just talk a little bit about growth plates. Growth plates are where we grow our bones from, and they're made up of primarily cartilaginous material. Very often we see Sever's disease in a younger population because our growth plates in our feet are the first ones to close. So anywhere from like 9 to 11, 12, that seems to be my Sever's pocket. Like I said, very often misdiagnosed. I think it's probably the most misdiagnosed of anything that I see, because the doctor will give them a diagnosis of plantar fasciitis sometimes, or I said before, Achilles tendonitis. When I'm assessing though, if I do a palpation right along the growth plate itself, the patient will jump off of the table, and that's how I kind of know. I see it a lot in dancers that are not putting their heels down when they're jumping, and or dancers that are, and this is gonna, I'll say this 5,000 times because this is all the foot pathology, dancers that tend to roll, force their turnout at their foot and the ankle, just because the Achilles doesn't line up in a nice way when you do that. So where it inserts onto the growth plate can get pulled and irritate the growth plate even more. It's also a super common injury with my gymnasts who are barefoot, and Irish dancers who tend to, they're not supposed to ever put their heels down. So if they don't have the strength to kind of control that deceleration, the tendon will pull on the growth plate and the growth plate will get inflamed. Very often we need to kind of like decrease the activity that is tugging on the growth plate for a period of time just to rest it. When I first started, doctors sometimes would completely non-weight bear the patient, which you do not want to do. You want to do modified activity, just not do the thing that's creating the pain and the dysfunction, which very often is jumping. So you can class and just avoid that.
Okay, yeah, because I think it's a great discussion, and I think you're right. As somebody who, some of my clients do go to, are able, I should say, to go to people who have specific training in dance, but of course, insurance and finances come in the way. And, you know, the Achilles is usually the victim. If it is an issue with the Achilles tendon, how does that come about? That's different than maybe the things we talked about previously.
So I find Achilles tendon issues to be very often It's like the structure versus function. If somebody has a not ideal Achilles, which is not their fault, they were born that way, I like to say, like Lady Gaga. So either like a really short Achilles that's preventing them from getting their heels down or getting a nice deep plie, or sometimes I'll have dancers with really long, skinny Achilles and not a lot of muscle mass kind of behind it to support it. These are the two kind of subsets that I see that end up having the actual Achilles pathology, really short or really long. You need kind of like right in the middle and good supporting musculature to support it.
When it is structural like that, I mean, what do you do if, let's say, you have a short one?
So I know. My heart feels for these people, but we do what we can to support everything around it. So if they have a really good, strong posterior calf, and I give them a lot of mobility exercises for their talocrural joint and their midfoot and their rear foot, like as long as they're like really cognizant of their limitation and work within the framework of it, their Achilles is fine. And there are plenty of beautiful professional dancers out there that don't have a deep plie and they make it work. Like it's all about understanding your body specifically as a dance medicine physical therapist. This is what I tell people all the time, and why getting injured isn't always a catastrophic thing, because you're learning to work with your body. And very often when we're in class, we're being pushed to look like somebody else. And that's not right. Like you have to, if you have a short Achilles, own it and learn to work with it. That's what I say. And once we do that, it'll leave you alone. It'll stop bothering you if you stop trying to push through it and make it something that it's not.
Yeah, and I think that's so fabulous, and I think so important for dancers, possibly even if you haven't had an injury, but just getting assessed so that you know what are your structural limitations that you shouldn't be pushing about. I think that's fabulous, and really nice to hear that they can still work with it.
Yeah, definitely.
Okay, so another big question. So let's say we all want beautiful, fabulous plantar flexed feet. There's a lot of information out there of how people can achieve that. Do you have any protocols that you feel like are safe for people looking to increase their point range?
Yeah, so it's really most of the time about strength. And very often people try to focus more on the mobility portion of it. I'm not a huge fan of foot stretchers or people shoving their feet under pianos or having a friend push down on their feet. You know, what this ends up doing is overstretching the ligaments, which are meant to support and protect, and the capsule. I will have to say though, the general kind of like guidelines that I use for people are know what kind of foot you have. So we have many different foot types, but I'm going to kind of, just for the sake of our time and everything, we'll pretend there are only two.
Okay.
Is a rigid, kind of more pes cavus or high arched foot type. And then there's like a floppier, doughier, pronatory foot type. If you take that floppy, doughy, or pronatory foot type, which is not a good foot, and you put it in a foot stretcher, you're going to do damage because you're going to be overstretching things that are already probably overstretched because you don't have as much kind of like integrity there. If you're the pes cavus rigid foot type and you do that, you're going to be overstretching and lengthening ligaments that are there to support that beautiful high arch. So in either scenario, strengthening is better than doing that kind of like passive stretching. So getting to know your foot and understanding what it is that you're asking from it, I think is really, really important. Now, of course, the aesthetic of a beautiful foot is like 85% of what it means to be a dancer. And there is a big chunk of the dancer population. Most dancers will say they don't like their feet, which is very disturbing to me, because I have dancers that come in that have the standard typical beautiful foot, and I have this like staggering response when they're like, oh, well, my bad foot, and her foot's like, you know, complete banana. So I think understanding what kind of a foot you have and also how to best strengthen it. So with those two different foot types too, you're going to be doing different things to strengthen based on what you're wanting to achieve in getting a better point. That's a very ambiguous, generalized answer, but
yeah, maybe for the sake
therapist, and they could teach you. And also know that your foot's probably not as bad as you think it is. So there.
I know this is a hard question because, as you said, there's so many different ways. Do you have, just for the sake of this platform, maybe a favorite exercise that could be? Okay.
Absolutely, positively. So I'm a huge fan of doming all the way, correct doming to build intrinsic muscles in the feet. Huge for a pretty beautiful, strong foot. I'm also a big fan of working with the half foam roller because it gives you the ability to do mobility, but also, so joint mobility either way, but then also a good platform for strengthening. So I have all of these on my Instagram page, by the way. And then the ball against the wall exercises. I don't know if you guys have ever seen those, but for those toe crunchers out there, which I'm sorry is all of you, you all crunch your toes. You know, you might not want to admit it, but you do. Ball against wall and just plantar flexing and making sure you're not crunching or gripping your toes. I'm moving away from TheraBand recently because I just feel like dancers abuse it. They don't know how to properly kind of like really articulate through their foot and keep their toes long. They often tend to use a TheraBand that's too strong for them and do a ton of toe crunching. So unless you're using a really, really light TheraBand and going through in a nice articulating way, I tend to stay away from that.
Yeah, I fully agree with that. I'm also on the camp of no toe crunching. And I think also finding the correlations of, if we're talking about the toe crunching, what I see a lot is maybe people aren't strong in their stabilizers. So when they're doing their adagio, they're still gripping in the toes, and then that can affect their plantar flexion also. Would you agree with that?
Oh, absolutely, positively. It is core and hips. Yes, Leah.
So if you want beautiful feet, got to get core and hips.
I mean, you really do. You really do. And I feel like we do have this like fixation on it, which is interesting. And I feel like it's important to kind of move away from that and challenge yourself in a different way. Like if we took all the time that we used putting our foot in foot stretchers and like did the strengthening, you would get stronger, beautiful feet. I always say to my dancers, I had a good foot. I didn't have a beautiful foot or that crazy banana foot, but I had a nice foot and I worked it and I domed my life away. And as a result, I had a pretty good foot. So, I think that everybody can start with this decent baseline and work their way up to a beautiful foot. I strongly, strongly support that. And I also say that high arched, hypermobile foot is a blessing and a curse, and you have to use it wisely because these are the dancers that I have in here all of the time. Because if you have this gorgeous foot, but you never learn how to strengthen around it and use it, you will get the stress fractures and the impingements and the tendinopathy. So don't be jealous of that dancer with the incredible foot, because unless they're doing the great work that they need to do to support it, they're going to end up getting injured. That's the bottom line.
So can we talk a little bit, because I think it goes along with the trying to achieve more plantar flexion. Can we talk a little bit about impingements? I think they're nice to go together.
Yeah, so we have two kinds of impingement, a posterior impingement and an anterior impingement. Anywhere in the body when we have an impingement, it just means that tendon and soft tissue is getting pinched in between bone. The FHL posterior impingement very often happens with dancers because we are, like this all the time. The FHL is a very long tendon, as I said, and it has a circuitous root, and it kind of dips underneath your talus bone, and that's where it tends to get impinged. Anterior impingement is when you have pain or like a feeling of a block in the front of your ankle when you're doing a demi-plie. This often has to do with the tissue that's on the talar dome, the top of the talus. There's cartilage there, other soft tissue, can get impinged. And very often with posterior impingement, you can also have something called an os trigonum, which is an extra bone on the posterolateral aspect of the talus that is pinching on the FHL. Os trigonums happen in about, I think it's 18 to 20% of the population. 50% of the time they're bilateral, both feet. And if you're a normal person, I always say that like dancers are abnormal, but they're exceptional. And you have an os, you're never gonna know. But because again, dancers live up here all the time, that's the position where the os really pinches on the FHL specifically. And that's when we get a posterior impingement because of the os.
Yeah, it's, it's so interesting. Keep talking, going back to the FHL tendon. I've had several clients who I've just said, can you just do me a favor and just ask your PT to take a look at that? Or, and then every single one writes me an email saying, that's such a strange request.
Right, so we have very specific ways of assessing for a posterior impingement, which is just like a forced plantar flexion, like I'll bring the foot into plantar flexion and give it a jerk. Also, just resisting your FHL, so resisted toe flexion. And very often the patient will say, ow, and they'll point to that spot I said before, right behind kind of the Achilles on the outside of their ankle. Yeah.
Okay, nice. So is there anything, is just the impingement that's not structural, do you just go back to strengthening and kind of making sure the mechanics are all working well?
Absolutely. It's a lot of times an instability issue where, again, these are floppy, hypermobile people. So they'll go up into that releve and the talus will slide forward. So it's really kind of my job to teach them how to not do that. Toe crunchers, huge impingers. So just learning how to articulate without crunching the toes. And people that tend to just sink in their point shoes without actually kind of lifting up. Sometimes it's also a point shoe issue. I would be remiss if I didn't say that. If the point shoe is not offering enough support or is ill-fitting, you get an impingement.
Got it. Okay, so what I would like to ask next is, so every dancer in the world has been told don't force their turnout.
That's so nice to hear because I came of age where everyone was like, no, force it. So I'm glad that people are being told that now. That's making me happy.
So, of course, I understand because I work with a lot of pre-professional young dancers and they want to achieve these crazy ranges. And I often find sometimes they're not even aware that they're forcing their turnout or pronating on their feet. So can you just explain a little bit of why that is so bad and why they really need to be careful to avoid it?
Sure. So our bodies are designed basically for us to transmit force through the center of each joint. So ultimately we should have a plumb line that if we dropped it down and if we were standing, our joints would be lined up so that the midline of the plumb line was going all the way up from the bottom of our foot all the way up to our head. This increases the mechanical advantage of each joint so that you're not overutilizing things that you shouldn't be, and you're not stressing the soft tissue and the structure, the bony structures in and around each joint. The second you force your turnout, you decrease the body's ability to be efficient biomechanically. And that's when we get the issues with tendons and bone. So that's kind of like the short answer. I could talk about this again for 75,000 billion hours, but back to the whole foot kind of talk with good feet, good turnout. Do we not talk about this every day, all day? This is all we talk about. Oh, and she has such good turnout and I don't have good turnout. Okay, well, guess what? Everybody's hips are different and you need to work within the confines of what your hip is able to do. That's the whole structure versus function thing too. And hips are like snowflakes. Everybody, there's so many different kinds. I've been doing this for so long and I very rarely do I see the same hip twice. So I think knowing what you have in terms of rotation and working within that, and certainly not going below the knee in the kinetic chain into your foot and ankle is a huge part of staying healthy. In addition to that, if people don't want to hear that side of it, from a technique standpoint, you're just able to achieve more if you stand with proper foot posture and utilize what you have for turnout. Ultimately, if you're trying to force the issue and make your body be something that you're not, you're never going to become technically proficient and a good dancer. It's the dancers that really know and understands their bodies and get to know them that achieve the most technically, and also have, most importantly, the longest careers, because they're not plagued by injury all the time.
For sure. Yeah, there's a really neat, just like generalized muscle testing that I do to explain that to people. And I'll just have them stand in parallel with their arm out, and I'll say, okay, you know, put them in good alignment. And when you're in really good, nice alignment, when all the muscles are working well, you can resist someone's pressure of your arm forward really great, and it doesn't seem like any effort. But just the smallest adjustment of maybe overextending your low back, when you go to do that little bit of pressure, it's like their arm has no strength anymore, and the system just breaks down.
Yeah, that's a great example. Absolutely, positively. I like to do, like, I'm sure you'll experiment with this too. I hear you when you're teaching talk about pelvic alignment all the time, and I feel like the pelvis is kind of like the cornerstone of everything. And very often, if a dancer's not going, not getting something, I'll cue their pelvis. I just very often like to do the very simple test of like really doing an aggressive tuck and trying to plie versus being just in your pelvic neutral and trying to plie. And the ease of motion that you have once you correct that, it's the same thing with forcing the turnout at the foot and the ankle. Go ahead and force your turnout at your foot and ankle and do a demi-plie. You're going to get stopped pretty early on, but if you hold your foot with good foot posture and do your demi-plie, you're going to get a greater demi-plie. We talked about that shorter Achilles person before. A lot of times they pronate in an effort to try to get more dorsiflexion. And as soon as I correct that, they have actually a greater range of motion if their foot is lined up.
Yeah, for sure. This is also, I think you'll get where I'm going with this, a nice segue to talk about bunions.
Oh, yeah. Well, okay. So the cause of bunions, I mean, there is like a genetic component to a bunion for sure, but for our population, it's created. The dancer creates the bunion because in forcing the turnout all the time, they're kind of just loading the inside of that first ray, the medial border, and hanging out there. And it overstretches the muscles and weakens the muscles on the outside of that first ray. So they get like an adaptive bunion and kind of like a sway, I call it, just from being in that position. And a lot of times I start my eval when I'm doing a dance eval in standing actually, and then I like to just play like detective and say, well, they're not going to have turnout on their left versus their right because they have a bigger bunion on their left and they're forcing their turnout more on their left. And I get them on the table and I do a passive assessment of their range, and sure enough, they have limited rotation in their left hip. So a bunion is they take off their shoes and socks and stand in front of me and I see that. I know 9 out of 10 times they're most likely forcing their turnout on that foot. And very often it is more pronounced on one side than the other.
Yeah, for sure. Yeah, and I think it's just good for people to know because maybe the old fashioned, but I feel like so many people blame the bunions on their point shoes and then they go directly to the tapered shoe. And it's like, there's so many other reasons you can have that.
Right. We can't blame anything on point shoes anymore. We can blame, because there's so many different kinds of point shoes out there and varieties, that there is a point shoe for everybody. I guess you can blame it on the shoe, but then correct it. It's a biomechanical issue. And the hallux itself is where we releve from. So if you have a bunion, and again, it goes to the congruency of the joint, and your joint isn't lined up. I did not bring my mobile foot. He's at a different facility. This is the unmobile one. But if he's not lined up and you go to releve, you're going to be compressing one side of the joint and gapping the other side of the joint. That's not going to be a stable foundation for you to do your releve on. You're on your first ray a lot for releve, and if you can't really access it properly, you're going to roll to the outside of your foot, or you're going to wing, or your releve is going to be a very unstable and unhappy place if you have a bunion.
Yeah.
Yeah.
So that reminds me, there was another question someone wrote in of, I know there's a big debate among dance teachers about the, I'm going to say the, even though they're not new, the newer types of shoes that are maybe not made of traditional materials like the gainer Mindens and the this or that. And I just want to be very careful. We're not talking brands. I just, from a medical point of view, think that there's any negativity for the newer type of shoes?
So because I'm super old school, initially I was very skeptical, I have to say, but now that the more synthetic made shoes have been out for a long period of time now, I've really developed a relationship with them and understanding when and where a dancer should be in them. Mm-hmm. There are certain dancers that really benefit from that type of shoe, and others that definitely should not be in that type of shoe. Does that make sense? So again, I can't really say a global statement, but I've had dancers that have struggled with the more traditional man-made type of shoe, and once they get in the gainer, it's kind of like the answer to all of their issues. So I think that it's more important to assess your pointe shoe needs as you go through your career, certainly, and that could change, a million times. And it's important to also understand that. I do have patients that, and the dancers are, some of my greatest educators when it comes to this, because I need to know what they're feeling and what the functionality in the shoe is. And I just have patients that say that they feel more supported, and I do a pointe shoe assessment and I take a look at them dancing in the shoe. Their alignment is better in the shoe than it previously. Does that make sense? So they also tell me, though, don't ever transition to one of those synthetic shoes in the middle of something because it does take an incredible amount of retraining. It is a completely different way of going up onto points. I just want to say a little aside too, because we were talking about the bunions. I feel like there is this like really weird movement of foot, because gainers very often come with these little inserts and stuff for you to put in to improve your alignment. But there seems to be this really weird movement of foot to give everybody a toe spacer, which is not appropriate. So if you don't need a toe spacer and you put a toe spacer, it's taking up valuable room in that shoe that you need. And it can also just really make you almost weak and like rely on it in a certain way. So really the true bunion pathology, where there is a significant angle of deformity, requires the toe spacer. You don't have that though, you should not have a toe spacer in your shoe.
Yeah, that's really great advice. Yeah, I didn't know that. I'm just as you, the farther away, the more removed I get. People come and tell me things. I'm like, really?
Yeah, no, so they come in and I do my pointe shoe assessment and they sit down and they take out their pointe shoe and then they take out the toe spacer and then they take out the little gel ouch pouch thing and then they just keep taking stuff out and I'm like, what are you doing? Like, why? I was like, why do you have this in your shoe? And they're like, I don't know, like, because they told me to. Or very often it's like, well, my friend wears a toe spacer. I'm like, so what? Do you have your friend's foot? No, you do not. It's baffling to me. But and very often, circling back to the impingements, I'll get dancers in with an impingement. I'll assess them with all this stuff in their shoe, go up on pointe, ow, I have pain. I take out the toe spacer, I go back up on pointe, they don't have pain. And they're like, you are a genius, PT. And I'm like, not really. I feel like that's kind of common sense, but okay. Impingements happen when you don't have enough room sometimes too. So really, reassess.
Yeah, that's awesome. On the pointe shoe, and I know kind of the theme that I hope that you're all getting from this is everybody's body is different. You can't put people into a box. However, as far as assessing, so let's take away the assessment of pointe, because there's so many things you can do to check for readiness, but just physical chronological age. Is there any research you're aware of that is looking into when is it appropriate for people to go on to pointe?
So everything that I've ever read and in the dance medicine community is suggestive of not looking at the chronological age, because very often our growth plates don't close in our feet until we're like 15 or 16 or, you know, so that's not something that we look at. We look at more the dancer's ability, their technical ability, how many times they're dancing per week is a huge, huge, huge question. And then overall, yes, structure, function, foot and ankle mobility, foot and ankle strength, mobility, core strength, pelvic stability. These are the things that I look at when I'm doing my point assessment, and overall calf strength and alignment on releve is huge. I'm not going to put a dancer up on point who can't achieve a nice, solid, clean releve with good alignment. So I don't look at age as much. I have a dancer who went up on point when she was 10, and she is very high level and beautiful, and we've never suffered any repercussions from it. And I've had dancers that are 14 or 15 that I won't put up on point because they're not technically ready for it or strong enough, or they have some underlying issue that would just make it dangerous. And it was Balanchine that said, you could put the dancer up on point, but if she can't do anything when she gets up there, what's the point? And I'm not a popular person when I go into the studios and do these point assessments, because very often the parent, the child, there's so much emotional kind of like baggage tied up into going up on point. But I just always have to reiterate that I'm doing it for the health and the overall safety of the dancer, in addition to the experience, because it's a negative experience and you can't get up on point and you see everybody around you is kind of getting up on point, you're not going to want to go up on point anymore. And as a dancer, I was kind of put up a little bit too early because my teacher really thought I was ready, and I had a very negative experience. I also grew up dancing in the 80s when there was like 3 types of point shoes. So trying to find a point shoe that fit my foot was an issue. But I think that ultimately a dancer needs to know that not only is it from an injury standpoint unhealthy to go up too early, or when you're not ready, I should say, but it's not good for your brain either.
Yeah, and I think I'm very thankful that there are people like you, even if you're not the most popular person in the room. Hey, neither am I sometimes. I always tell people I'm okay to be the bad guy. I'm fine.
Right.
But it's hard for teachers because, you know, you build this relationship with your students and the parents. And I just hope that people realize when they do go to someone like you with an assessment that you have their best interests at heart for them to both be a dance professional if that's their dream, but also for their health. So yeah, don't be too hard on people if they tell you're not ready for a point.
Right. Yes, definitely.
And I'm forgetting now, and I can't remember where the source was, but a couple of years ago, I feel like it was the Royal Ballet that did a research project to see when their dancers went on point. And they really found that the ones that went on point early versus the ones that went on point late, there was really no difference. They got to the same end result. Right. So that's usually what I tell people too. If you know, it takes you a little longer to get there, it's fine. You're all going to get to the same end, you know, end lane.
Yes. Yes, I work with a dance teacher who always says, we're all going to Disney World. Some of us are just going to take a plane. Some of us are going to drive. Some of us are going to walk. I love that.
I love that. Oh, that's awesome. Yes. Well, I think those are all my questions and all the questions everyone had. I think let's end with, if people would like to get in touch with you and communicate further, how can we do that?
So I have an Instagram page. It's CT Dance Physical Therapy. And on Facebook, it's Connecticut Dance Physical Therapy. So you can certainly IM me on either one of those things. I also have a website, Connecticut Dance Physical Therapy, and you can message me through there or send me an email.
Awesome. Well, thank you so much, Samara. This was really, really fabulous and really enlightening. And yeah. Thanks for joining me.
Thanks so much, Leah, for having me. Thank you so much. Bye.